Recording in progress.
Good afternoon, friends. I'm Dr. Prince James from Narvi Hospital, Vellore. At the start, I want to thank Team Lupin for arranging this webinar for all of us. We shall be discussing today COVID-19, third wave, and the role of vaccines. After me will be Dr. Vimy Varghese, who will be discussing an update on COVID-19 treatment. And then Dr. Rajgopal will be discussing how to manage the complications of COVID-19. So without much delay, let's go on the presentation. So a lot happened over last 1.5 or 2 years, I will say. We learned a lot, new things in our lives, lockdown and treatments. And as a pulmonologist or any doctor, I will say in India, we were over busy over last 1.5 year. Something happened which was unprecedented. Lot of difficulties were there, but a lot of new things also we learned. So objective of this webinar is we can learn something from first and second wave, though there were troubles. And then a lot of people keep asking us, what about third wave? So a lot of alarm bells were there. We will see that also. And then we will look into that, how to deal with the third wave. What are the factors responsible for it? Because if we understand that, then probably we can try to control it, minimize it as much as possible. And vaccines are there now. We will see the effect of vaccines now. The first wave, vaccine was not there. Second wave, when it came, vaccine was about to roll out. So now we have vaccines at our hand before the third wave starts going up. And then we will see what we can do to protect ourselves from these ongoing waves. So let's talk about second wave and lesson learned. It started around somewhere March 2021, and it was much larger than the first one of 2020. And it was one of the largest humanitarian crises in our country, which we experienced, shortage of hospital beds, cylinders and oxygen cylinders and therapeutic drugs and vaccines, a lot of hassles. And what were the problems there? What was responsible for it? There were multiple factors. One of them was a variant of COVID-19 virus. We called it, later on we came to know it was Delta variant. And then at the same time, when first wave came down, lockdown opened up, there was a change in our behavior all across the country. There were large gatherings, there were meetings that also fueled that second wave. And then there was some lack of preparedness that we were found on the wrong foot when the numbers started rising up. And as I said, vaccine was about to roll out. It was available in our other countries, in our countries about to start. So there was a huge, large unvaccinated population, which was susceptible for virus infection. So those were the things which happened. And if we look into each of these 4 factors also, probably we can prepare ourselves for the oncoming waves, third wave or maybe other waves also, and minimize the problem which we felt during second wave. So third wave is a ticking timeline. Everybody talking about is media, government agencies, and we heard a lot about it. Even when the second wave was going on, people were talking about third wave will also come. Big people also, scientific advisors and ICMR, and a lot of people said about the third wave and that it's inevitable, it will come. And probably this time, because second wave affected more younger population, and also prediction was there that third wave will now affect children because they remain by God's grace protected in the first and a little bit in second wave also. And then we saw these kind of predictions also. Prediction was given that if everything goes back to normal, then probably third wave will come by October, and then the peak will be less than second wave, but will be high peak. The prediction was 3.2 lakh cases per day. And then Other scenario given was if the new variants starts coming, new virulent viruses, new variants are there, then peak may go even higher than the second wave, 5 lakh cases per day. And the third scenario put forward was that if you follow the strict interventions, lockdown and all the things, follow the COVID appropriate behavior, still wave will come by October and it will be lower than the second wave, maybe 2 lakh or something cases per day. Now we are on 9th October and by God's grace, till now numbers are okay, manageable. They are not at least rising exponentially. So country is gradually getting back to the track. So looks like these predictions were made for our safety, for to prepare us for the oncoming wave. So I won't say they were wrong, but yeah, by God's grace, it didn't happen when it's October there and it is not happening. So we should be happy for that. So what causes waves actually? These infections, viral infection, we always knew they come in waves. And that happens because virus keeps mutating. For example, even influenza virus, why are we vaccinating every year? Because virus mutates, influenza virus mutates, and every year we have to come up with a new vaccine to control the infection of influenza virus. Similarly, this COVID virus also kept on mutating. So when the new new variant comes, they may be, not all of them will be more infective, but some of them, if they're more infective, they can cause infections, newer infections and increase in infection. At the same time, it's a tussle between the virus and our immunity. So if our immunity is not there against this virus and we have susceptible population, like if we can see here, if there is no herd immunity and people are susceptible, all of them, and then one person is infected, then it can he or she can infect number of them over there. So that's how the virus spread happens and the number starts going up exponentially high. But if the community or the population already has immunity against the virus, the green ones we can see here, then if there is a person who got infected with the virus also, will infect other, but will not be able to infect too many people, and virus can be contained. Transmission can be reduced. So how do we reach this green state? This we reached by two ways. One, by these waves only. First wave, second wave, when people get infected by the COVID virus, their bodies develop immunity against the virus. So they developed by natural infection, they gain this immunity. And the second way is to give the vaccines, and by that our body achieves immunity against the virus. It so happened that now vaccines are also there, and country has gone through first and second wave. So both the conditions are met. So in our country, there will be a lot of people who already have either had natural infection of COVID or they got vaccinated. We will look into both the factors. So actually we are now in this zone. There may be some pockets in our country where people are susceptible, but we will look into that. But majority of how many of us are in this zone, we will just look into that. That will give us an idea how the third wave will behave. And we'll also look into these variants, how they are coming up so that we can deal with them. So let's first deal with the seropositivity or this immunity. So in India, there was fourth sero survey was conducted. It was conducted in June and July. So this was the time when second wave was on the descending path. It was coming down gradually. So June, July, it was conducted, and neutralizing antibodies, antibodies which can neutralize the new infection with coronavirus, they were found in 68% of people. People who are aged above 6 years. 68%, I will say, is not a bad number. If we see the previous figure, not everybody has immunity against the virus, but if majority of them have immunity against the virus, then the chain of transmission can be stopped and virus infection will not go in very high peak waves as it happened in the second wave. So 68%, is it a good number? Yeah, it is a good number. 60-70% if people are having immunity against the virus, then probably chain of transmission can be blocked or can be reduced. So more than 2 in 3 people in our country have already been exposed to the virus, either to the infection, natural infection, or they got the vaccine. If you see this number and try to compare what happened after first wave. After first wave in December 2020, seropositivity was 24%. This figure tells us, see, 24%, then a large number of people in our country will be still susceptible to the virus. And that's how after December, January, February, and second wave came and went quite high up. But now after the second wave, because so many people got infected, now this number of seropositivity is 68%. So that gives us some reassurance that now country is prepared, and the next wave there shouldn't be so many susceptible people that this virus should affect us like the second wave. If you look at the seropositivity from age point of view, from 45 to 60 years of age, seropositivity is 77%, while in children it was 57%. So the question when it comes that the next wave, first wave, the old age people's 55 year and plus or 60 plus, second wave, younger population got affected. So when third wave comes, it is going to affect more children and more trouble. But this data says, though we assume that children were safe in our country, but it still says that 57% of them got the seropositivity, means they got the infection, but probably did not develop severe disease. That was good for us. And that's how around half of the children already have got the natural infection. So they have some seropositivity, and that in one way is good for us, because as and when the vaccination starts in children, probably we can protect our children against severe infection or new infections as well. In comparison to men, women are more seropositive in our country. And if we compare urban versus rural populations, in cities, people are more seropositive. And that is also during second wave, it was bad, but now it will help us, because in the cities only crowding happens. So they are only overcrowded, and we travel in overcrowded buses and trains. So actually when seropositivity is higher in the cities, that helps us in controlling or breaking the chain of transmission. What is the effect of vaccine? Because not only second wave happened, but in our country, vaccination also happened. So if we see the effect of vaccine, even in the sero survey, when the vaccination just started trying to take up, if you see at that time, people who were surveyed in 4 sero surveys, 62% had no vaccination. So majority of them had no vaccination, but those who had vaccination, 25% of those who had single dose, and 13% of those were fully vaccinated during this time. And if we see in this number, seropositivity was 81% among those who received single dose. So in a whole population, it's around 68%. But in those who received one vaccine, seropositivity goes to 81%. 81% is very good number for breaking the chain of transmission for the virus, for protecting us against the virus. And those people who received both the vaccines, both the doses, in them it was seropositivity rate is around 90%. So it's really, really good. And it will surely protect us against the oncoming viral infections. Among the healthcare workers, because the vaccination started first in healthcare workers, still some people could not take it for various reasons, but seropositivity, if we see in healthcare workers, around 85%, which is also good in providing the protection. If we see the COVID vaccination in India now, that we were discussing the previous figures from June, July, but if we see today, in comparison to that now, around half of the population, 49% of population of our country have received single dose, and around 18 or 19% of people of our country have received both the doses of vaccine. And that is a good news, and because it will help us in facing or fighting with this virus. And at the same time, this also tells us this is the way to go. We have to keep on vaccinating our country people and try to reach as much as possible to 100%. We have to vaccinate the whole population of our country if we have to defeat coronavirus. So combining the whole seropositivity, immunity, if we see natural infection, vaccine, a lot of people in our country have now antibodies or immunity against this virus. So if we look at that, this was the first wave, went up to 1 lakh. In April and all, this is the second wave, went up to 4 lakhs. And right now we are here in October, it is lying low. So it looks like because so much infection happened during first and second wave, and then in this period of time, we started vaccinating. Because there is a lot of immunity by natural infection or by vaccination, the third wave, we predict that it should be a gentle wave and shouldn't be as big or as severe as second wave. At least it may come in waves. This graph may go up and down a little bit, but shouldn't be as bad as second wave. Unless two COVID caveats are there, unless a new variant comes, which is more infective and which can surpass our immunity, which we received from either natural infection or from the vaccine. So this is a war kind of going on. If the virus develops a new variant, then only this thing happens. So we should focus on the finding out variants. In the coming few slides, we'll just look into that quickly. Or the second thing is we ourselves start doing the same mistake we did after the first wave. Stop following the COVID appropriate behavior. Go in large gatherings and all mass meetings. COVID can come back again. We should be very careful about it. So let's talk about COVID variants now. This is a SARS-CoV virus, and we see the spike protein. What happens during mutation? The mutation happens in the gene, and genes make a new protein. So spike protein can change. So this is a new mutant virus, a new spike protein. What this protein can do is sometimes it can enable virus to combine with a human airway cell more effectively. So their infectivity increases. So new variants, some of them can have more infectivity than the old variant. And the other thing it can do is our body has antibodies against this old variant of virus. So antibodies are combining, neutralizing the virus here. But when the new variant comes and makes new spike proteins, the antibodies against those proteins are not effective. And that's how virus can defeat our immunity and move on. So that is also one possibility, but not very high possibility, but yes, sometimes it can happen. We will look into that. What is the new variants coming as the Delta and all coming, how the vaccines are doing. So if we look into this slide, I just combined the whole variants into one slide. So if the Alpha, Beta, Gamma, Delta, all we learned from Latin language, we have all names were given to these variants. So Alpha was found in UK, September 2020. And from the original virus, which started in China, transmissibility was 40% more. And Beta, it was 50% more from South Africa. Gamma was found in Brazil, 2.5% more transmissible than the original. So we can see what we discussed in the previous slide. As the new variants come, sometimes some of them can be more transmissible. And that's how the virus waves starts. Because they're transmissible, they can create another wave. And then this Delta, which is 60% more than Alpha. Alpha is 40% more than original. So it is almost double than the original. And that's why the second wave came in our country, the Delta variant. And it also said that viral loads were 1,200 times higher than the original infectivity. So when the viral loads are higher, the people will emit more virus, they can infect more people. At the same time, it is also said that Delta virus requires less viral particles to infect a person. So it worked in all the three ways: more infective, higher viral load in person who get infection, and then from that person, when it spreads, it requires very little amount of virus to infect another person. And that's why its spread was so much, and second wave happened in our country. However, if we look into all these variants, and there are a few more variants, and Delta plus also data is coming up. But however, till now we know that it is not too much different from Delta. And if we see the vaccine efficacies, Covishield and Covaxin 2 we have, and both offers against all of them around 75, 80, 65, 67% protection. So quite good protection against this viral variant. So we shouldn't lose heart. Vaccines are working, they are effective, and vaccination is also gradually increasing in our country. So this is the way to go. I think we have a good tool in our hand to fight the virus, good armament, and we can defeat the virus. More variants are coming up. That's what virus does. We will come to know in coming months or years more about them. What about the risk of COVID among children? Though it was predicted that children will get more affected and more sickness, but however, till now there is no evidence that children are more at risk from Delta variant, which is the right now running variant. And I already said that it is not like children are totally naive from virus. and that's a totally susceptible population. No, more than half of our country's children have already got exposed to the virus. In two different sero surveys, one the 4 sero surveys, and this is done by All India Institute. In both of them, it was found around 55% of children already have antibodies against the virus. So what should we do? Combine these two things: vaccines with which we can fight the virus, some natural infections we received during first and second wave, and then how to fight with the virus. So the best strategy is faster vaccine rollout. We should vaccinate as much as possible. Vaccinate our children also as and when the trials get published. And then I think once the vaccination with 2 doses gets completed, we should start thinking about the booster doses, hike up the immunity. And at the same time, we should keep an eye on the newer vaccines, more effective vaccines, so that we can vaccinate our population and boost up the immunity of India against this virus. At the same time, we should keep a close eye on the virus. So enhance genomic surveillance to identify more and more variants of concern. And so that if we know that new variant is emerging sometimes, as in second wave, we saw it started in Maharashtra, started gradually spreading out. So if we know the new variant is coming up, probably we can do more effective containment, proper lockdowns. And that it is good thing in India that there nowadays a lot of genome sequencing is being done, and there are labs which are identifying it. So this should be done and more so that we can find out as and when new variant coming, we should find out as quickly as possible to contain it. And then prevention is the best strategy. We should not forget about COVID appropriate behavior. Masks, social distancing, hand washing are very, very important. And all of us should do, and we should keep on advocating it. Avoid mass gathering, that mistakes of second wave we should not repeat again of first wave. Avoid mass gathering, avoid workplace related then workplace related initiatives can be done. Work from home options, a lot of people are doing, companies are doing. And then, yeah, we should prepare ourselves with the new healthcare facilities, oxygen supply, more ICU beds, more pediatric ICU beds. Last, just 2 slides, I will say some example from UK. This, if you see the example of UK, what was happening in another country, they opened up the country and people are meeting now. In UK, if you see the vaccination has reached around, in UK, around 1 dose has been given to 73% of population. 2 doses have been given to 67% of population. So more than around 2/3 or 1/4 of population got vaccinated. If you see the infection, what is happening in their country, 1, 2, 3rd, and probably one more wave going on over there. So infection rates are quite high. But if you see this effect of this vaccination on this, we have to see here what is happening to the admissions and deaths. So though the infection wave is going on, infection is there, but the admission rates are low, death rates are even low. And that is happening because of this vaccination, whatever natural infection happened over the last 1.5 years. So that tells us that vaccination really, really helps. It's a very effective tool. Even though the country is open, infection rates are high, but still the hospitalization and deaths, severe COVID can be prevented. So, and this infection rates are high because in UK, they are testing at a very, very higher rate. So if you test more, you can find out more. But that is good to find out. But those people can be treated at home isolation, so mild COVID. They won't require admission and will not succumb to the disease. So I will complete with a slide that a third wave should be a gentle wave, shouldn't be as big or as severe as second wave, unless a new variant comes, and we should keep an eye on that. And we should not, or we stop the COVID appropriate behavior, which will be a grave mistake. We shouldn't do that. And vaccine are the key. So vaccinate and our patients related as much as possible. Thank you. Thank you very, very much. So the next session will be Dr. Reema Trial. He is a consultant pulmonologist from Nervi Hospital, Vellore. He will be updating us regarding the treatment of COVID. As the newer vaccines are coming, treatments are also emerging, and a lot of newer things are there. So let us learn from him how to treat COVID patients now after the second wave. Dr. Reema?
Yes, sir.
Yeah.
So can you stop sharing the screen, sir?
I stopped, I think.
Oh. So thanks, sir, for the introduction. Myself, Dr. Vimmi Varghese, a consultant pulmonologist in Nervi Hospitals, Vellore. So I'll be updating about the newer recommendation of the COVID-19 treatment and what we have learned in the past and how to go ahead. So briefly in this session, we will be describing about how to classify the severity of COVID-19, most of the things which everybody knows, and what are the new additions in the treatment, especially based on the post-exposure or what is post-exposure. Uh, Secondly, about what are the treatment changes in a non-hospitalized patient, and especially about the hospitalized patient, and what are the different trials that forms the main treatment regimen. So, as you know, there are
Sorry, that screen sharing is we are unable to see your screen.
Is my screen, everyone able to see the screen now?
It's there now, correct.
So as we know in the previously, there are multiple treatment options, and everybody used to be worried about what treatment to be given, or is my treatment correct, or will my treatment be effective, and what to do, and there is a lot of panic. So now from the last first and second wave, we have some idea, and frequently the guidelines are changing, and our Indian government and all the governments are frequently updating. So there are more insight to the above problem. So as we go through, the main thing is as we see for COVID, how to classify. So broadly from the WHO, in the living guidelines, they have classified broadly into three. That is non-severe, severe, and critical. So severe means when the saturation is less than 90%, if there is signs of pneumonia or in signs of respiratory distress. However, critical refers to those requiring a life-sustaining treatment, ERDS, sepsis, or septic shock. And the non-severe category is being further divided into asymptomatic, mild illness, or a moderate illness. Now, mild, specifically, even though it is not there in the living guideline, most of the guidelines refers to where there is no predominant respiratory symptoms, but they'll have all the myalgias, loose stools, and non-respiratory symptoms. And the saturation is predominantly more than 94%. Moderate classifies to where there is a feature of respiratory illness in the form of cough or breathing difficulty. However, the saturation seems to be more than 94%. The moment when the saturation takes a dip, that is a time when we say there is a severe COVID-19. Now there are different scenarios where the treatment should be initiated. One is when there is a exposure to a COVID patient, especially when that other relative or the other person is staying with the patient. And other is when non-hospitalized patient, that is we are not being admitted, but we have COVID. And another scenario is when we are hospitalized with COVID. So first we'll go to what are the post-exposure prophylaxis, or first of all, what is post-exposure? Now to classify as exposure, there should be two main things that should be there. One is about the vaccination status. Either we are not fully vaccinated, that is, we are never vaccinated or received a single dose less than 2 weeks, or fully vaccinated but not able to mount an adequate immune response because of multiple reasons. One thing is when we are receiving an immune suppressant drug, or we are suffering from an immune deficiency, etc. Another point to be noted is when there is an exposure history. That is, we had a recent exposure to an individual that has SARS-CoV-2, or we are basically living with a person who is having a SARS-CoV-2, like for example in nursing homes and prison. So these are the two essential things to classify as exposure according to the CDC guidelines. Now, CDC has come with a emergency use for two drugs for a post-exposure. One is about a double monoclonal antibody called bamlanivimab and itesivimab, which is given as an IV infusion. And this dose should be administered within the 7 days of high-risk exposure. And it is indicated in those with a high risk of progression to COVID-19. So in short, those person with elderly, more than 60 years, multiple comorbidities. So that is the patient whom we are thinking in this category. Now, the basis for this monoclonal antibody was based on a BLAZE-2 trial, which is a phase 3 randomized control trial. And what they did in this trial was it included multiple people and from different nursing and other living facilities. They randomized into 1:1 ratio, and the randomizing to the monoclonal antibody arm and was a placebo arm. They conducted weekly swabbing, and what they found was there was a significantly lower incidence of mild or worse COVID-19 in bamlanivimab arm than in a placebo arm. Like there was a 8.5% in the monoclonal antibody arm as compared to 15% in the placebo arm. Now, what is the other option? Most of us might have heard about something called cocktail antibody. So cocktail,
can
yes.
we make it full screen?
Yes.
Yeah, thank you. Yeah, thanks.
So cocktail antibody, as you know, it's called keserivimab or imdevimab. Usually, this is an cocktail antibody that has been given as an IV infusion, which for post-exposure prophylaxis, and those with a high risk of progression, like as I've said earlier. And the post-exposure criteria remains same as the earlier drug, and it should be given within 7 days of high-risk exposure. And the basis for the drug was a trial, which was a double-blind placebo-controlled phase 3 trial, which was conducted in multiple places in US, Romania, and Moldova, and included around 1,500 patients. And in that 1,500 patients, what they observed was there was around 81.4 risk reduction in the cocktail antibody arm as compared to the placebo arm. And this group of patients also, they conducted the weekly swabbing, and the analysis was continued for 4 more weeks after enrolling the trial. And there was significant less number of mild or moderate COVID-19 in the cocktail arm. So that forms a treatment for the post-exposure prophylaxis. This post-exposure prophylaxis with cocktail antibodies available in multiple places in India, and we also do provide this service. Now, as I said, classifying the asymptomatic to asymptomatic or pre-symptomatic, where there is no features of any complaints. However, mild refers to those who has a complaint that is not respiratory, like for example, they have loose stools, myalgia, fever. Or moderate refers to those with respiratory complaints with the saturation of more than 94. However, the complaints are like a lower respiratory complaints like cough and breathing difficulty, etc. Now coming to management of non-hospitalized patients. So according to CDC, the non-hospitalized patient, there are three recommendations from CDC. Either we can manage symptomatically that we are currently giving. However, those with a higher age, with a high risk of comorbidities, there are 3 monoclonal antibodies that is being currently available in US. However, we have only one, that is a cocktail antibody. So among the 3, either one is being preferred by CDC. One is bamlanivimab plus itizumab, which I already said, which can be given as an IV infusion, or as a cocktail antibody by keserimab and imdevimab as an IV infusion, or the new addition monoclonal antibody is called sotorivimab. So these are indicated in those with a high risk of progression to severe COVID-19. And CDC definitely recommends against the use of dexamethasone or other systemic corticosteroid to mild to moderate illness. Now we come to hospitalized patients. Now in hospitalized patients, there are the clinical scenarios that arises are those who are receiving some very minimal amount of oxygen, those who are on NIVs, or those who are ventilated patients. Now we'll go through each scenarios. So first scenario that we come across is the hospitalized and doesn't require oxygen. So all the guidelines, especially the CDC and the infectious disease itself, they recommend against the use of dexamethasone or other corticosteroids in this juncture. However, there is insufficient evidence for or against the routine use of remdesivir. So why we are why CDC or other guidelines is telling to use dexamethasone, remdesivir. I'll go to each trial in a very short way so that everybody gets an idea. Now, in hospitalized and those who require a supplemental oxygen, CDC recommends either to use one of them. So one among the drug is remdesivir only for those who require a very minimal oxygen, and dexamethasone plus remdesivir for patients that require increased amount of supplemental oxygen, or remdesivir only when the combination with remdesivir is not available or cannot be used. Now, this is the new change that is come in the guideline of Infectious Disease Society. That is when they are hospitalized and when they require an NIV or a high frequency nasal cannula. So earlier we were giving predominantly dexamethasone plus remdesivir or dexamethasone only. However, currently the new changes are there is a new addition to the regimen that is called baricitinib, which is a JAK2 kinase inhibitor. So when the oxygen requirement is increasing, or we feel the systemic inflammation has sets in, or the inflammatory markers are still on a higher trend after the dexamethasone, there is a role for JAK2 inhibitors like baricitinib or the IV tocilizumab to one of the above two option. Or if above baricitinib or tocilizumab is not available, there is a role for tofacitinib instead of baricitinib, or IV saralimumab instead of tocilizumab. I understand that the tocilizumab is costly drug as compared to the dexamethasone or baricitinib. However, the baricitinib, I'll come in detail why we include baricitinib and what we have to be cautious while starting the baricitinib. Now the hospitalized and those requires mechanical ventilation on ECMO, steroid remains same, that is dexamethasone. However, we feel the within 24 hours of admission to ICU, in case of the worsening scenario, there is a role for IV tocilizumab. Preferably the role comes earlier in the admission, earlier when the admission is made, or earlier we feel the timing has started. That is a time where we should start a tocilizumab, because that is when we have the adequate trials which conveying the above information. However, if tocilizumab is not available, there is a role for saralimumab. Most of them will be very familiar with dexamethasone and remdesivir dosing, and I feel that no need to go for that. I will just go through this baricitinib. It is a JAK2 kinase. It's a JAK2 inhibitor, and it is depending on the renal clearance. So we have to do a baseline renal function before starting a baricitinib. And based on that, starting dose is from 4 milligram once daily. And based on renal function, we alter the dose of the drug. Now, what are the different trials which form the basis of treatment? First trial that I will go through is the ACT1 trial, which is a multinational randomized controlled trial that compare remdesivir to a placebo in hospitalized patients with COVID-19. So it showed no significant benefit in patients with mild to moderate COVID disease without a supplemental oxygen. This group included around some 138 patients. However, the other group, that is the patient who required oxygen supplementation, there is an improved time to survival, but not the high flow oxygen, non-invasive or the invasive mechanical ventilation. So when they did the post-hoc analysis, it appears to have a substantial survival benefit in this subgroup. Most of them knows about the recovery trial. It's a last trial that's been conducted in UK. And in that study, around 2,000 patients were randomized to either dexamethasone, and the trial includes the dose of 6 milligram daily for 10 days. And other group randomized to 4,300 patients to the usual care. So what they observed was among hospitalized patients and who are critically ill, the odds of mortality at 28 days was 34% less among patients treated with glucocorticoids than among patients not treated with glucocorticoids. And at 28 days, the patients receiving dexamethasone were more likely to be discharged from the hospital. So among the hospitalized patients with severely ill, the 28-day mortality was 70% lower in the group that received dexamethasone than in the group that did not receive dexamethasone. So in the subgroup analysis of the patient without a hypoxia, there was no evidence of benefit. That's the reason why we can see that dexamethasone is indicated from the time the patient starts receiving the oxygen therapy. However, actually there is no role or the benefit when there is no evidence of hypoxia. Next main trial is about the Barcelona Trial, or is called Co-Barrier Trial. It includes around 1,500 hospitalized patients in the trial, and the inclusion criteria was those with the COVID-19 with the elevated inflammatory markers, and they were randomized to 1:1 ratio to either baricitinib or a placebo for a care of up to 14 days. So what they came to a conclusion was there was no difference in the primary endpoint of progression to high flow oxygen, NIV or invasive mechanical ventilation or death by day 28 between baricitinib and placebo. However, the mortality by day 28 was only 18 in baricitinib, and there was 13% in the placebo arm. So there was around some 38% reduction in the mortality for baricitinib. And the difference in mortality was more pronounced in the subgroup of 370 patients received high flow oxygen or NIV. That's the reason we can see in the new edition, when the patient was on high flow or when the patient was on NIV, the baricitinib was introduced. Now comes the Reema and the recovery trial. So this is another trial that is being widely studied, and that is being used for the tocilizumab. Both trials reported a mortality benefit for tocilizumab, those who experience rapid decompensation and who are recently admitted to ICU, especially those who required invasive mechanical ventilation. The Reema trial enrolled patients within 24 hours of admission to ICU. And the prior trial that has enrolled patients in the post of ICU or received oxygen support for more than 24 hours or ICU admission failed to show clinical benefits for tocilizumab. So that was the reason we always say that as soon as patient comes to the ICU and those who are on mechanical ventilation, sooner they administer the tocilizumab, more the better. So a recovery trial also suggests the clinical benefit for tocilizumab, but the problem was in that trial there was also a corticosteroid that was also given. So we cannot purely say based on only on the tocilizumab benefit. So there are different drugs that is not useful in COVID-19. So we can see that right from ivermectin to HCQ, and recently we heard about even stem cell therapy. So CDC has given a clear indication why they are saying all these drugs are not useful, with the proper flow chart and the different parameters. So if somebody wants to know beyond this, in CDC website, especially the September 221, the latest current year's edition, it's very clearly given. So coming to the conclusion, the post-exposure prophylaxis with the cocktail antibody, it's something new and is an emerging concept. And different scenarios have a very clear treatment guidelines as of now. We have to be very cautious while using the drugs, and do not use the drug with an unclear benefit as mentioned. So all those we are rating, we should be really helpful that government is giving us a vaccination. So wait for your shot and get vaccinated early. Thank you. Our next speaker is Dr. Rajagopal. He's a consultant pulmonologist working in Nervi Hospitals, Vellore. He'll be telling about the different complication and how to manage it. Over to Dr. Rajagopal.
Hello, good evening, everyone. So now that we have seen about the complication, seen about the treatment, how we go about with an acute COVID management, to know about how to treat the complications that appear through this COVID-19. Just give me a minute. Okay, you're all able to see my screen?
No, Raj, it hasn't come yet.
Just a minute.
Yeah, now it is coming up.
Able to see? Sure.
Yeah.
Okay, let me start. So this presentation will be a very short presentation, and it is going from the common complications to uncommon complication, and it is purely based on our experience, how we treated patients with post-COVID complications in Nervi Hospital. So the pulmonary sequelae of COVID-19, which will be dealt with symptom-wise, which we have seen in last maybe around 6 to 7 months, is go from persisting breathlessness and cough, which is the most common, persistent fatigue and persistent oxygen requirement, persistent air leak, which may or may not require ICD and bronchoscopic closures, and post-COVID lung cavitatory lesions. So the first case will be a 34-year-old male, initially admitted with severe COVID-19 and required admission for about 25 days and was discharged on oxygen and then tapering dose of steroid. Came back after some 2 to 3 weeks with increased oxygen requirement and breathlessness. So the initial differentials considered were community-acquired pneumonia on an already compromised lung due to COVID-19, acute pulmonary embolism, or a pneumothorax, which is secondary to lung damage that is caused by COVID-19. So this is an X-ray which we can see. The left one is the newer X-ray, and the right X-ray is the older one, which was at discharge. So as you can clearly see, there is a left-sided secondary spontaneous pneumothorax. So this patient was, the management was as simple as left-sided ICD insertion and lung expanded in the post-ICD X-ray. The ICD was removed after 5 days. Patient is on follow-up for last 3 months and physiologically doing well. So here we need to know that pneumothorax is one of the common complications of diseased lungs, and more so in post-COVID patients as they have a profound lung damage that may be still ongoing. So coming to the second case, it's a 42-year-old male from our local Vellore with no comorbidity, had a prolonged stay in ICU with critical COVID-19. He was on prolonged mechanical ventilation and tracheostomy was done. And the patient clinical course was punctuated by recurrent secondary spontaneous pneumothorax bilaterally with multiple ICD insertions. So the challenges in the management of this patient was, the patient was on high supports on ventilator. The intensivity was not able to ventilate the patient properly, with bilateral ICD drains continuously bubbling with air leak, and tracheostomy was in situ, and recurrent pneumothorax, which was mostly on the left side. As we can see on the pictures, that air leak can be seen on the ventilator graphs with air leak that is showing in the expiratory flow. And also in the X-ray, there is a large left-sided pneumothorax, which was initially managed with ICD insertion. So now let us have a short slide on what is air leak and what is a bronchopleural fistula. It's a communication between the main stem, lobar or segmental bronchus and the pleural space. As we can see in the picture, it may be either from the main stem or the lobar or the segmental bronchus into the pleura. So can we identify the problem bedside? Yes, we can. There will be, as you can see in the video, there is continuous bubbling of this ICD. And also it can be bronchoscopically identified where the air leak actually happens by a flexible bronchoscope with balloon blockers, where we sequentially block each and every segment and find out where the block causes a decrease in air leak. And in this case, it was found in the left lingula. The persistent air leak, the bronchopleural fistula, was identified in the left lingula. So coming to the treatment option in such cases where it was difficult to ventilate the patient because of persistent air leak, the surgical closure of air leak with muscle patch is one of the options. But here it was not an option because already the patient is on ventilator with high ventilatory support, where surgical procedures will lead to more morbidity and we may lose the patient. The less morbid procedures would be bronchoscopic closure with airway stents or occlusive materials like methyl 2-cyanoacrylate, which is a fibrin glue, spigot insertions, endobronchial injection of sclerosants, or endobronchial valves. As we can see, the three-sized spigots like 5, 6, and 7 millimeters, or the endobronchial walls where we can see, and also which can be placed in the appropriate segment using a bronchoscope. So as we can see in the pre-procedure X-ray and the CT, there was a left-sided pneumothorax which was not resolving with the conventional management. And we can see like ICD was placed on either sides, whereas post-procedure with bronchoscopic closure with endobronchial blocker was done. And the post-procedure X-ray is showing a well-expanded left as well as right lung, and ICD was removed post-procedure. So this patient was doing well on the ventilator and cough and decreased exercise tolerance. As we can see, he's not too old for the symptoms. So the lung function test was done, where the left-sided spirometry shows a FVC of 67%, whereas the 3-month spirometry was showing a better FVC of 72%. But even then, at the end of 3 months, also he was continuously complaining of breathlessness, where we can see we have something called a forced oscillometry technique to find out the small airway obstructions. As we can evidently see on the x-axis, a frequency at 5 Hertz, where we can see the curves are well beyond the lower limit of normal. Whereas going on further to like 30-35 Hertz, it reaches near normal, which clearly says that there is evident small airway obstruction. And now we come to forced oscillometry. How is it different from the conventional spirometry? Forced oscillometry doesn't require any forced maneuvers as we do it in a spirometry. And normal tidal breathing is all what we need. Even children can perform the test as there is less of cooperation that is required. And it is more sensitive than the spirometry in early diagnosis of small airway disease. So this patient was managed appropriately with bronchodilators, and he's coming for follow-up even after 5 to 6 months, and he's feeling better. So coming to the fourth case, a 51-year-old male, severe COVID-19 with persistent oxygen requirement and uncontrolled diabetes mellitus, presented with purulent sputum and continuous fevers. The X-ray, as we can see, right upper lobe is showing a big abscess cavity with air fluid levels. The abscess cavity drainage was done with a pigtail under radiology guidance, and the pus aspirated grew a mixed bacterial growth. He was initially treated with antibiotics, as it was typical for a lung abscess in a post-COVID patient with uncontrolled diabetes. This is a CT thorax patient, CT thorax of the same patient, where we can evidently see fibrous strands inside the abscess cavity, and also air fluid level that we can see on the right-sided image. In view of failure of medical management, the patient underwent a right upper lobe abscess drainage and external drainage was done. As the upper lobe bronchus was short and bronchoscopy guided silicone stent placement was done on the right main bronchus till bronchus intermedius, as we require the right upper lobe takeoff to be covered, as it can lead to cross infections. So this is a post-procedure status where we can see on the right main bronchus there is a silicone stent in place, which is also evident, as we can see here on the X-ray, where you can see the dot nodules present, which is the right main bronchus silicone stent that is placed. And there is an ICD in situ, and the right upper lobe abscess cavity has been taken off, and now the remaining lobes have expanded nicely to cover up the space. Here the diagnosis which was coming out of the blue was the surgical specimen showed evidence of invasive mucormycosis along with tissue invasion as well as angio invasion. Patient was started on appropriate antifungal therapy and is doing well on follow-up. So after the presentation, the take-home messages are post-COVID sequelae presents in different scenarios ranging from subtle respiratory symptoms to severe infections which require complicated bronchoscopic procedures. And high index of suspicion and systematic work can lead to prompt treatment and recovery of the patient. And pulmonary function test and bronchoscopy play a vital role in managing such post-COVID patients. Thank you.
Thank you, Raj. Wonderful presentation. And thank you, Vimi. That was very nice to learn about the newer development. Looks like we have few more things in our armament to deal with the COVID pneumonia and disease. Now I'm trying to find out the question link. Just give me 1 second. Technical team, can you help us? Are there any questions over there? I'm unable to see the questions right now. I think there are, till we are waiting for the questions, I'll just ask Dr. Vimi that this cocktail treatment or antibody treatment, will it work in patients who are developing breathlessness or who are still requiring low oxygen or something, or how do we define that? Which patients are most appropriate? And is there a time window also?
So the am I audible, sir?
Yeah, loud and clear.
Yeah. So the cocktail antibody, as per the guidelines till date, it's not been indicated for those with an oxygen therapy. So that is point number one. Secondly, the age factor, whatever as per the guidelines, is more than 60 years, and those with the multiple comorbidities. And these is the population whom which they have studied, and we have a recommendation till now.
Sure. Thanks for that. And now we can see there are two more molecules there, no? Than monoclonal antibodies. So is there any comparison between them? Which one is better? As in, or are they available in India, or if they are available, then how to compare?
Yes, sir. Other two are not available in India, sir. But there are no comparative studies between the cocktail, that is our Kesarimumab and Imdivimab, and other two drugs. As of now, we don't have a comparative study.
And Dr. Raj, thanks for the presentation. Regarding this post-COVID fibrosis and assessment, and when is the time that after the discharge we should do the PFT and start assessing and imaging, or what is the timeline when we should start doing the assessment and plan therapy for them?
Usually, the the assessment should begin from the discharge, like exercise assessment, oxygen requirement, and other simple things. Whereas the patient who with severe COVID get discharged usually will not be able to perform any spirometries, and CT will just show the ground glass opacities which was persistent previously. So like there are no guidelines as such telling that at what time it should be, but 1 to 2 months will be an ideal time to follow up such patients. And thereafter, based on their symptoms, if they are persisting, may go like every 3 monthly or even 2 monthly.
So you recommend that sometime we should give to lung to improve instead of jumping over on the repeat the CT and all. Any experience, any words on like nintedanib therapy, or where do we recommend? Or
yes, sir. As of now, the trials which are going on is yet to be completed, both of pirfenidone as well as nintedanib, whereas the interim analysis is yet to come. As of now, in short, small trials, there are no benefits as such to be shown with nintedanib is effective. But as we see catching up fibrosis early and treating them, even though there are no evidence, it's better to start something with, and then later on we can stop if the patient is improving like better than what we expected. It's better to start early and pick up. And we have to wait for evidence as of now. There are multiple randomized control trial, even nintedanib with a placebo is being tried, for which the results are yet to come.
Sure. Yeah, that's and Dr. Vimi, how many patients you have experience with this antibody treatment?
As of now, around 25 patients, sir. We have experience in our Nervi hospital. So most of them had most of them were elderly with multiple comorbidities who were administered the cocktail antibody, and around 93% were discharged on the same day.
Wow, that's a good number, and quite reassuring also, because that's where we think that disease may progress. So that was the most susceptible and population where we used to think it is going to progress. So Jinsi, are there any questions from your side? Jinsi, Selva, Lupin team, any questions from your side?
No, sir. That would be it from the audience side, actually.
Sure. So if there are no more questions, shall we conclude the session?
Yes, sir. Sure. You can conclude if we have covered the agenda and the closing remarks.
Sure. So thank you very much. Thank you, Vimi. Thank you, Raj, for wonderful presentations and update on COVID. And I want to thank again Lupin team who helped us in conducting this webinar and learning more things about COVID management. Thank you. Have a good day.
Thank you.
Recording stop.